Good morning, everyone, and I'm happy to welcome you all for another discussion. So here today we are going to discuss about renal recovery when it comes to hemodialysis dependent acute kidney injury. And as we all know, when do we start hemodialysis or renal replacement therapy when it comes to acute kidney injury? So when the patient develops life-threatening complications as like if the patient develops a fluid overload or because of impaired solute clearance, the patient might develop uremic complications like uremic pericarditis or uremic encephalopathy. And it could lead to severe hyperkalemia, which could cause cardiac arrhythmias and cardiac arrest and severe acidosis. So these are the indications to start or initiate renal replacement therapy or hemodialysis. So why these indications have been formulated to be the initiating factors? Because if these functions of the kidney is not performed even for minutes to seconds, that might lead to life-threatening complications and patient might succumb to death. So that is why, even though the kidney is performing so many other complications, so this has been the indications to start renal replacement therapy. Now we have started hemodialysis or renal replacement therapy in acute kidney injury, and we have evaluated the patient for the cause for the acute kidney injury, and we have sorted that out. And now the patient is recovering. So now our target is how to assess the renal recovery, and patient is dialysis dependent still. So do we have to keep the patient as an inpatient to assess the renal recovery? No. So if the patient is hemodynamically stable and if there is no pressing indications to keep the patient inpatient, you can discharge the patient and space out the dialysis and assess the renal recovery as an outpatient. So that is the aim of this presentation. So how do we assess? So what is the first sign of renal recovery? Is it the creatinine? Can we rely on the creatinine? No, because when we do the dialysis, there would be, if you check the pre-dialysis creatinine, it would be on the higher side. And if you check the post-dialysis creatinine, it would be on the lower side. Does that indicate that the patient has recovered renal functions? No. So that indicates our dialysis machine is working fine. So creatinine is not going to be a marker to assess renal recovery when it comes to hemodialysis dependent AKI. So if you want to rely on the creatinine value for assessing the renal recovery, patient should not be on a renal replacement therapy mode. So this chart illustrates how to assess the renal recovery. So again, the same indications. So if the same functions could be performed by the native kidney, then we don't have to support that kidney with artificial support, that is dialysis. So what are those essential functions? So if the kidney itself could maintain the volume status of the patient, and if the native kidney itself could maintain the solute clearance, and if the native kidney itself could maintain the potassium at the safer level and maintain the acid base balance at the safer level, then we don't have to do the dialysis. So once we are sure that these functions could be maintained by the native kidney, then we don't have to continue dialysis. So that is how we assess. So if you go through the sessions, so you'll have to put the number of dialysis sessions here and the session date. And the first sign of renal recovery, as we all know, it's the urine output. So you'll have to ask the patient to document his 24-hour urine output each time he comes for the dialysis sessions. And usually they have found in the trials that if the patient could develop or if the produce around 1 liter to 1.5 liters of urine without diuretic, then it is enough for solute clearance as well. So we'll have to document the urine output, and if it is around 1 liter to 1.5 liters, and it would give us some form of an evidence to say that patient has recovered his renal function. So we can think about withholding the dialysis. And then we need to assess whether the volume status could be maintained with the native kidney itself. For that, interdialytic weight gain is going to help us. So how do we calculate the interdialytic weight gain? So we check the pre-dialysis weight and we'll document the post-dialysis weight, and patient goes home and comes back for his next dialysis. We would imagine in 3 days time. So his weight was around 50 post-dialysis weight, and he's coming with a pre-dialysis weight after 3 days with a weight of 53 kilos. So what is the interdialytic weight gain between these two dialysis sessions? It is 3 kilos. So which shows that even though the patient is producing urine, it is not enough to maintain his volume status. If his native kidney is able to maintain his volume status, interdialytic weight gain would be 0 or negative. Why? If the kidney is functioning well, it needs to maintain the body's volume status in a zero balance. So this is the first thing that we assess. Second thing is, we need to assess whether the kidney itself could maintain the solute clearance, that is creatinine clearance, whether it is able to do it on its own. So for that, we use this pre-dialysis creatinine and post-dialysis creatinine. For an example, patient comes with a creatinine of 900. After the dialysis, it has been cleared up to 300, and patient goes home, coming back in 3 days time again with the pre-dialysis creatinine of 700, which indicates that from 300 it has gone up to 700, which means the native kidney itself could not maintain an adequate solid clearance. So that is why the creatinine has gone up within the body, because it has not been cleared. But if you say the creatinine is stuck around the same level, then you don't have to do the dialysis and ask him to come back again in 3 days time with the pre-dialysis creatinine value and check whether it is the same, or whether it has gone up. If it has gone up, that means it has built up. So you'll have to arrange dialysis. If it has not gone up or it has reduced, then it is suggestive of there is a adequate solute clearance, and you can think about withholding the dialysis. And if two consecutive serum creatinine values are coming down without dialysis, then it is more suggestive of a renal recovery. And the third thing, so if the potassium at the pre-HD level is maintained in the safer level, that is less than 5, then that means the native kidney itself could maintain the potassium at the safer level. So it doesn't need an additional support. Same thing with bicarbonate. So if the patient could maintain an adequate bicarbonate level to maintain the pH in the normal level, then we don't have to support the thing. So simple as that. So this is how we assess the renal recovery. So every time the patient comes for the dialysis, we have to assess these factors and determine whether this patient would need dialysis. If not, then space out the dialysis. What does that mean? So you don't do the dialysis if it is not indicated with the biochemistry and the clinical status of the patient, and ask him to come back in 3 days time, reassess the thing. And once you are confident that two consecutive serum creatinine reports are coming down without the hemodialysis, then you could be sure that patient has recovered renal functions, and you could think about taking the dialysis access out or dialysis line out, and patient could be monitored as an outpatient at the clinic level up until his creatinine comes back to his baseline. Thank you.